Good evening, everyone. On behalf of NASH 24 into 7, I extend a warm welcome to our public awareness program on fighting the fatty liver. NASH 24 into 7 is dedicated to providing top-notch education and awareness program for healthcare workers, patients, and caregivers. Today, we are honored to have with us Dr. Shalini Sharma, a renowned gastroenterologist from Agra. She is a leading expert in her field, known for her compassionate care and expertise in treating gastrointestinal and liver conditions. She brings a wealth of experience and patient-centered approach to her practice at Prabha Hospital, Agra. We deeply appreciate your commitment to raising awareness about liver health. So, without further ado, I invite Dr. Shalini Sharma, ma'am, to enlighten us on this topic. Over to you, ma'am.
Thank you. Thank you, Riders, for such a beautiful introduction. So today on the occasion of this World Liver Day, we are going to study about liver, not exactly study. We are going to introduce a lifestyle for the betterment of liver. So what can we do so it can make our liver healthy and of course, there are some points we are going to learn in this presentation. So let's start with the presentation. Slide, please. So if we look into a basic anatomy, location, and structure of liver, so liver is basically a largest internal organ made up of cells called hepatocytes, means liver cells, and located in the upper right corner of the abdomen. It is quite soft reddish brown in color and weight approximately 1.5 kg with a difference of 100 grams in men and women. And it got divided anatomically into a left lobe and a right lobe. The larger one is called the right lobe, and where we see the smaller one, that is a left lobe. And we have, if we look into the blood supply, we have got two dual blood supply in the liver. That is very beautifully functional because it has got more significance when our liver it suffers by any sort of drugs, any sort of alcohol, or anything. So blood enters liver through portal vein and lymphatic artery. Yes, that is a very important. That portal vein is the vein. Can you move back to the previous slide, please? That is a very important vein that supply blood to the liver, despite of its name vein. And blood leaves liver through the hepatic vein, drainage by inferior vena cava, and then to the heart. Next slide, please. So if we look into the hepatocytes, these are the major 80 to 90% of total liver volume. These are called as liver cells. And if we look into its surface, it has got larger number of microvilli. Microvilli mainly for the secretion and absorption purpose. It has got large nuclei and numerous mitochondria. And we have another cell called hepatic stellate cells. Hepatic stellate cell, the main function is to store vitamin in these cells. And we do have Kupffer cells also. These are the fighting cells in our liver. Next slide, please. So main issue is what is the function of liver? What does exactly liver do? Basically, liver is monitors all the organ. Basically, liver is the monitor of our body. It maintains everything. जिसको हम बोलते हैं ना कि आज के अगर लैंग्वेज में यूज करें कि it's a CA of our body. It maintains, it accounts everything like what our body is having. Like हमारी body ने अभी क्या लिया, कल क्या लिया, आज क्या लिया, लास्ट मंथ क्या लिया, क्या टॉक्सिन्स लिए हैं, क्या अच्छी चीज ली है, लाइफस्टाइल कैसी है. बेसिकली इट्स अ मॉनिटर, it counts everything. So it maintains the composition of the blood so that all other organ can perform efficiently. That is a very important thing because जब हम patients देखते हैं cirrhosis के, जल्दी सुना ही होगा आसपास किसी को कि लिवर की दिक्कत है, शराब की वजह से लिवर डैमेज हो चुका है. तो हमने ये भी देखा होगा कि उनको किडनी की भी दिक्कत आती है, वो बेहोशी में भी चले जा सकते हैं, उनको इन्फेक्शन भी बहुत जल्दी होता है. तो why is it so? Because liver maintains the proper functioning of all other organs. That is a very important thing. If we look into the proper function, obviously it is very plays a very important role is glucose, lipid and protein metabolism. हम जो भी खा रहे हैं, whether it is fat, whether it is carbohydrate, whether it is protein, it plays a very vital role in its metabolism. Very important role in protein synthesis. That's why हम liver के सारे patients को कहते हैं increase the protein intake. पनीर अंडा हम इसलिए एडवाइस करते हैं बिकॉज इफ योर लिवर इज अफेक्टेड, इफ योर पेशेंट इज हैविंग सिरोसिस, तो प्रोटीन सिंथेसिस कम हो जाता है. देन बिकॉज इट इज वन ऑफ द वेरी इंपॉर्टेंट फंक्शन ऑफ लिवर, देन ऑफ कोर्स इट इज अ डिटॉक्सिफिकेशन सेंटर. सो हम जो भी खा रहे हैं, whether it is an addiction, whether it is an alcohol, whether it is an any drug, any sort of toxic drug you are taking, or any sort of allopathic, herbal or ayurvedic medications that is affecting the liver. There are many drugs which affects the liver. So basically liver mainly to detoxify it. Liver tries its best to detoxify it. So प्रोडक्शन एंड सिक्रीशन ऑफ बाइल, ऑब्वियस है पित्त बनाना, पित्त का सिक्रीशन मैनेज करना, ये लिवर का बहुत इंपॉर्टेंट फंक्शन है. नॉट ओनली गॉल ब्लैडर, बिकॉज पित्त सुनते ही हम सबका दिमाग सिर्फ गॉल ब्लैडर पे जाता है. इट्स नॉट लाइक दैट. पित्त का बनना, पित्त का बहाव किस स्पीड से होना है, कितना होना है, कहाँ होना है, ये सब लिवर डिसाइड करता है. गॉल ब्लैडर सिर्फ उसे स्टोर करता है. एंड ऑफ कोर्स स्टोरेज ऑफ लिपिड soluble vitamins and B12, it is also important function of liver. Next slide, please. So if we look into the first important function, metabolism of various glucose, lipids, and proteins. If we look into the glucose, it is absorbed by the small intestine and transported to the rest of the body. So molecules also stored by the hepatocyte and release the blood when blood glucose levels drop. So as I've already told you, it's a monitor of our body. So whenever you are low of sugar, whenever your body is running out of glucose, your hepatocytes have stored glucose in it. They release it. Metabolism of lipid. Of course, for metabolism, they have maintained the metabolism of cholesterol and lipoproteins also. So it's a quite detailed process. I don't think we don't need to go deeper into that. Amino acids, protein metabolism, they are the building blocks of protein. The amino acids are the building blocks of protein, and these are synthesized by the liver, converted into the another amino acids like with enzymes like alanine aminotransferases. So these are the enzymes that are released from the hepatocytes into the bloodstreams when liver cells are damaged. So that makes a very common test of liver function test, that is alanine aminotransferase and aspartate aminotransferase. These are nothing. These are the enzymes which are very helpful in the liver functioning. Next slide, please. So all plasma proteins except immunoglobulins are synthesized by the hepatocytes, in which albumin is the most abundant one, and it maintains the plasma oncotic pressure. And decline in the albumin synthesis leads to edema. Yes, it is one of the important cause of edema. There are other many causes of edema in cirrhotic patients also, but yes, decrease in the albumin, low albumin is one of the most important cause of edema. Pedal edema, ascites in the patient of cirrhosis, पेट में पानी भरना, पैर में सूजन आना. Low albumin is the most important cause in these patients. Globulins, these are the complement proteins, and these are basically defense proteins, and we have important role in defense against disease producing organism. And if we look into the clotting coagulation factor, these are activated during blood vessel injury and leading to the formation of clot. Again, this is very important. See, clotting factors, they are released by the liver. So in the cirrhotic patients, the tendency of bleeding is quite increased as compared to the normal one. So these all are things मैं आपको जो साथ साथ बता रही हूँ कि ये सारे चांसेस, ये सारे कॉम्प्लिकेशन की रिस्क हमारे लिवर पेशेंट्स में बढ़ जाती है. ये सिर्फ इसी से ही एक्सप्लेन हो पा रहा है क्योंकि हमारे लिवर का काम ही यही है. अगर हमारे लिवर का काम ये कम होगा तो इनके कंजिक्यूटिव एक्शंस जो होंगे, रिजल्ट्स जो होंगे, वो हमें देखने को मिलेंगे. नेक्स्ट स्लाइड प्लीज. Bile. Bile is produced by the hepatocytes and secreted into the biliary canaliculi, approximately half liter in amount per day. It consists of various ions, cholesterol, lipids, bile salts, bile acids, and bile pigments. So basically, bile pigments consist of bilirubin, breakdown product of heme, that is part. Bilirubin transported from spleen to liver by albumin, where it is conjugated, thus help in EPS creation. It is responsible for the yellow color of the bile, and jaundice is due to the accumulation of the bile. So basically, पीलिया बनना. अच्छा, एक चीज मैं इसमें जरूर बताना चाहूंगी कि पीलिया बनना सिर्फ लिवर की बीमारी का लक्षण नहीं होता. Definitely we need to rule out the liver function, but there are other बहुत सारे और भी reasons हैं, especially blood के पेशेंट जो होते हैं जिनको हीमोलिसिस हो रहा होता है, ब्लड टूट रहा होता है, या जिनको ब्लड कैंसर का ट्रीटमेंट चल रहा होता है, या फिर ब्लड की जिनकी बीमारियां होती हैं, उनको भी बिलरुबिन बढ़ जाता है, बट दैट विल बी इन अनकॉन्जुगेटेड बिलरुबिन राइस, एंड दैट इज नॉट ड्यू टू प्राइमरली लिवर डिस्फंक्शन. तो ये एक चीज मैं क्लियर करना चाहूंगी. दो मोस्टली पेशेंट्स में, if your patient is coming with jaundice alone, so definitely get an liver imaging, get a basic liver LFT testing done before you proceed to the other causes. Next slide, please. So look into the functions. Digestion. Of course, in the duodenum, it acts as a biological detergent emulsifying fat. As we all know, bile is a very important constituent in digestion of fat. Increases surface area of fat, thereby enabling enzymatic action and breakdown into fatty acids, which can be absorbed more easily. This This function is basically regulated by gallbladder. See, what does gallbladder do? Gallbladder checks out what are you eating. If gallbladder sense that you are eating too much fat, आपने आज बहुत वसा युक्त खाना खा लिया, बहुत चिकनाई वाला खाना खा लिया, तो what does gallbladder do? It increases it secretes the absorbed bile. जो उसने bile अपने पास स्टोर कर रखा था उसको secrete करता है, so that fat digestion में easy हो. बट गॉल ब्लैडर रिमूव होने के बाद जो कुछ पेशेंट्स में इंडाइजेशन का इश्यू होता है, पेट फूलना और स्पेशली हैवी खाना नहीं खा पाना होता है, वो बिकॉज ऑफ दिस फंक्शन डिस्टर्बेंस होता है. सो इट हैज नथिंग टू डू कि गॉल ब्लैडर हट गया तो पित्त नहीं बनना, ऐसा कुछ नहीं है. इंपॉर्टेंट पार्ट इज कि पित्त टाइमली रेगुलेट होके सीक्रेट नहीं हो पा रहा है. So if we look into the excretion, cholesterol, bilirubin, and numerous drugs are excreted by bile, enters large intestine, and are removed by the body in the stools. Next slide, please. Detoxification center. Of course, it detoxifies very potential toxic substances in a body, alcohol, drugs, hormone, and breaks down amino acid byproduct ammonia, detoxified by the liver into urea and excreted. That is one of the important tools to diagnose. See, ammonia is a byproduct of breaking down amino acids. So if ammonia is a very important marker of hepatic encephalopathy, though I would not say it is 100% sensitive marker for hepatic encephalopathy, but definitely if your patient is, अगर आपका patient cirrhosis का patient irritable है, not sleeping frequently, so definitely we can get an ammonia level done to sense that whether it is encephalopathy or not. तो दीज आर सम टेस्ट ऑल्सो जो बेसिकली ये फंक्शंस, ये जो हम नॉर्मल फंक्शंस जो हम लिवर के देख रहे हैं, ये आगे भी काम आएंगे जब हम देखेंगे जब लिवर हमारा फंक्शन कम कर देता है तो व्हाट आर द टेस्ट जो हमारे खराब होते हैं. Kaffer cells, I have already told you, these are the fighter cells, these are the macrophages, remove microorganism that invades the blood. Next slide, please. So if we look into the other functions, it stores site of iron, lipid soluble vitamin A, D, E, K, and of course water soluble vitamin B12. We have hepatic stellate cells that store the vitamin A and inactive under normal circumstances. Liver injury transforms them into the fibroblast, which produces the collagen, and chronic liver injury leads to the constant production of excessive collagen, resulting in fibrosis and ultimately the cirrhosis. Next slide, please. So what is the pathogenesis? What are the symptoms? What are the manifestation of liver disease? So we have already दो हमने सिम्टम्स पढ़ के काफी कवर करा कि सिम्टम्स क्या होंगे अगर लिवर का फंक्शन डिक्लाइन होगा, बट स्टिल लेट्स जस्ट मूव टू द थ्योरी बेसिक्स, सी कैसे कैसे क्या होता है। सो अगर हम लिवर डिजीज की बात करें तो वी हैव अ hepatocellular injury, we have non-hepatocellular injuries. In case of non-hepatocellular injuries, we have cholestatic, vascular, and metabolic injuries. Next slide. So if we look into the cholestatic, see hepatocellular liver disease, we'll discuss later. It is basically the the things which are directly injury, which are causing direct injury to the liver, whether it is toxin, whether it is any drug, or whether it is any infection, hepatitis. So the things which are directly affecting the liver, directly causing the hepatocytes injury, that are hepatocellular injury. If we look into the non-hepatocellular liver disease, cholestatic liver disease, that affects the biliary system, leading to the obstruction of the flow of bile and accumulation of the bile in the hepatocytes. We have PSC, we have a PBC, sclerosing cholangitis and biliary cirrhosis, in which there is an inflammation, subsequent necrosis of the bile duct cells, and ducts become damaged and replaced by the scar tissue. Then we have drug-induced cholestatic reaction. Injury to the liver, it is the potential adverse effect of most drugs. Next slide, please. We have non-hepatocellular liver disease like vascular disease, vascular origin. Vascular origin can be liver itself or in other organs like Budd-Chiari syndrome, portal vein thrombosis, anything which are ischemic cardiac, ischemic this hepatocellular injuries. We have congestive heart failure, that is common abnormality of the circulations, leading to the failure of the heart muscle pump power, leading to the accumulation of the veins. The backflow of blood will be accumulated in the liver, leading to the congestion of hepatocytes and therefore decrease in the functioning. And thrombosis and embolism. We have abdominal infections and we have Budd-Chiari syndromes. We have metabolic liver disease. They are very inherited disorders that can cause a metabolic liver disease. We have hemochromatosis. Hemochromatosis is an abnormality of the iron metabolism that patient absorb and retain excessive amount of iron in the liver, and which leading to the progressive fibrosis, thus cirrhosis. We have Wilson disease. In this, hemochromatosis is all about iron. Wilson is all about copper. Apart from the liver, Wilson also affects the brain, kidneys, and eyes. Next slide, please. If we look into the hepatocellular, we have a direct dysfunction like in case of hepatitis A, B, C, E. And we have a type of hepatitis, toxic, autoimmune, and viral. We have toxic hepatitis due to drug or any chemicals. We have autoimmune hepatitis due to autoimmune nature. Next slide, please. So if we look into the toxic hepatitis, alcoholic and acetaminophen overdose. Alcohol is due to prolonged heavy drinking, fed droplets in the liver, leading to the necrosis, inflammation, and alcoholic hepatitis. First, your liver starts to swell. शराब से पहले कहते हैं ना लिवर पे सूजन आना. There will be liver starts to swell, then there will be an inflammation, and then it will lead to cirrhosis eventually. Acetaminophen overdose, like paracetamol poisoning, liver generating toxic intermediate. With overdose, these accumulate and leads to the necrosis. Autoimmune hepatitis usually affect the young female and destruction of hepatocyte by the body immune systems. Next slide, please. So viral infection, they are the most common cause, and virus causing liver disease, but not targeting liver. Cytomegalo, herpes, and Epstein-Barr virus. They have the virus targeting liver, that is A, B, C, D, E, G. A or E causes acute disease. G discovered recently, closely related to hepatitis C. Next slide, please. So this is the basic important chart. The important thing that needs to be remembered that apart from B, all are RNA virus. And if we look into the mode of transmission, A and E, they have a food and waterborne transmission, while B and C and D, they have a sexual bloodborne transmission. And AE, these are usually acute course, max they go for 6 months, not more than 6 months. While the B and C, D, they usually progress to the acute or chronic course, in which the propensity to progress to chronic liver disease will be very high, is very high in hepatitis C infection. Next slide, please. So what are the consequences? Of course, inflammation initially produces a protective response. Chemical release from the buffer cells, lymphocytes, macrophages, and natural killer cells. And later, it will be a chronic inflammation. There will be a necrosis, destruction of hepatocyte by the T cells and natural killer cells. Then eventually, it will set to a fibrosis. Next slide, please. So what is fibrosis? Fibrosis is nothing. Fibrosis is formation of the scar tissue in the extracellular matrix. So it is a normal mechanism in the body, like जहाँ कहीं भी हमें भी चोट लगती है, whenever we get any bruise or abrasion something, we eventually got a fibrosis. But what occur in case of internal organs? The fibrosis shrink the organ. The fibrosis decreases the function of the organs. So in patient with these hepatitis, alcohol, metabolic, vascular, drug-induced hepatitis, so basically cell responsible for formation of scar tissue, as we have already discussed, it is the stellate cells, which basically stores the vitamin A. These are the inactive cells. And after the injuries, these cells get activated and transformed into a fibroblast, which can proliferate, contract, and produce large amount of collagen that leads to fibrosis. Next slide, please. So what is fibrosis? Fibrosis series harmful effects on the function of hepatocytes. Hepatocytes will lose microvilli. Microvilli, if they lose, they decrease the ability to absorb the substance from the blood. What they absorb? They absorb the toxins from our blood. So that is why they're important. Fibrosis blocks the fenestration, thereby obstructing access to hepatocytes to the blood. And if injury continues, fibrosis definitely changes the architecture of the liver, change the anatomy of the liver. It progresses to cirrhosis. Next slide, please. So cirrhosis is nothing. Cirrhosis is the end stage of fibrosis. And there are the three main characteristics. We have a necrosis of parenchyma. We have a nodular regeneration, that is formation of nodules of regenerated hepatocytes. We have a changes in the liver structure due to above which compressed and distorted blood vessels. Next slide, please. So cirrhosis progressive and may take decades to develop, but in early stages can regress. Basically, cirrhosis do not regress. The important part is chronic liver disease can regress. See, cirrhosis and chronic liver disease, they are not same thing. If your patient is having chronic liver disease, इसका मतलब ये नहीं है कि he is a patient of cirrhosis. Cirrhosis is the end stage of chronic liver disease. Any liver disease which is continuing more than 6 months is chronic liver disease. It can simply a chronic viral hepatitis also. तो अगर आपके किसी भी आपका या आपके किसी भी नोन का 6 महीने से ज्यादा लिवर का इलाज चल रहा है तो परेशानी हुई, इट इज नॉट सिरोसिस, ऐसा नहीं है. क्रोनिक लिवर डिजीज जरूर हो सकता है डिपेंडिंग ऑन द रिपोर्ट्स. सो क्लिनिकल प्रेजेंटेशन जरूरी नहीं है सब में कुछ क्लिनिकल प्रेजेंटेशन हो. ऑफ कोर्स यू पेशेंट कैन बी प्रेजेंट विद डिक्रीज एपेटाइट, फटीग, मलेज, और the major complication of cirrhosis are due to portal hypertension only, that is ascites, hepatic encephalopathy, bleeding, hematemesis, altered behavior. Next slide, please. So this is the to assess the prognosis of cirrhosis. We have a 5 clinical measurements, functional measurements known as childhood score, in which we have bilirubin, we have albumin, we have PT-ANA, prothrombin time. That means आपका ब्लड कितना ब्लीडिंग टेंडेंसी है. वी हैव असाइटिस, वी हैव एन्केफेलोपैथी. दी जब हम फंक्शंस ऑफ लिवर पढ़ रहे थे, वी हैव ऑलरेडी डिस्कस कि हाउ दीज थिंग्स डिरेज्ड व्हेन द लिवर इज नॉट फंक्शनिंग प्रॉपर्ली. तो इसमें स्कोर रहता है लेस देन 7, 7 to 9, देन मोर देन 10. नेक्स्ट स्लाइड प्लीज. Yes. So basically we have A, B, C. A is usually compensated. Compensated means your liver is compensating with the functions. Means there will be no ascites, there will be no encephalopathy, and the liver function are somehow not much deranged. And 7 to 9 is decompensation. B and C are decompensation, and B and C both are candidates for transplantation. And if we can see the life expectancy, this is a very important question. patient usually asks the liver ki patient, ma'am, what is the life expectancy? See, for one patient, it is very difficult to say कि ये इतने दिन जिएंगे, इतने दिन. It's very, very difficult for a doctor to say like this. So these in approximately, these are some population studies. Like child A patient can progress to 15 to 20 years if everything goes all right. If he does not drink any sort of alcohol, any sort of insult will not be there. Child B and C, like C, it's a very late stage decompensated liver disease. We have a expectancy of 1 to 3 years only, and it depends variably if your patient suffers any sort of major trauma in between or is continuing alcohol intake. So it differs very significantly between patient to patient. Next slide, please. So a small brief introduction about SCC. SCC is it's a primary cancer of the liver. It's a very highly aggressive cancer, and main important causes are cirrhosis. So most important, the things which are causing cirrhosis can produce hepatocellular carcinoma, like your viral hepatitis B and C, your alcoholic liver disease, hemochromatosis. These all can cause hepatocellular carcinoma directly or by cirrhosis. It's a highly aggressive cancer, usually in advanced stage when detected and not treatable by surgery, chemo, not well tolerated, and transplantation is used for treatment. Not in every case. We have a different score, Barcelona grading, BCLC grading for that. So I don't think that it is quite deeper into that. Next slide, please. So basic sign symptom. That is a very important slide for the general people. We have jaundice. Jaundice is nothing. Jaundice is the yellowish discoloration of eyes, your mucous membrane, your skin. So basically, if your bilirubin is more than the normal level, it can cause jaundice. That's it. What are the causes of jaundice? There are many causes of jaundice. So just by having high bilirubin, you do not decide that this is due to liver disease only. We have portal hypertension. Portal hypertension is increase in the portal pressure in the portal vein. So it can lead to ascites. It can lead to bleeding in the varices. We can say खून की उल्टी आना. It can lead to hepatic encephalopathy. Then we have ascites. Ascites is accumulation of fluid in the abdominal cavity. It is usually a first sign of decompensation. जिसको हम बोलते हैं ना decompensation liver disease, decompensated liver disease. Ascites is usually the first sign of the decompensated liver disease. Then we have hepatic encephalopathy. It can basically the toxins, the neurotoxic substance affects the brain because they are not filtering out by the liver. So it can be range from simple irritability, not able to sleep in the night, to comatose. So there are various grading of encephalopathy. It can range from grade 1 to grade 4. Next slide, please. So these are the basic signs and symptoms. Just to summarize, we have a neurological encephalopathy. We have a skin jaundice, rashes. In hematological, we have pancreatitis can also cause myelofibrosis and pancytopenia, of course. We have anorexia, nausea, vomiting, abdominal pain. In reproductive, we have a testicular atrophy, gynecomastia, impotence. We have a potassium and sodium defect in that. And cardiovascular, we can have fluid retention, peripheral edema, and ascites. Next slide, please. So how to evaluate this? We have a liver function test and measurements of element associated with the normal functioning of liver. We have this measurement of element associated with the hepatocyte damage. So it is used to estimate the severity of disease. Next slide, please. We have AST, ALT level, basic LFT should be done, SGPT, SGOT, and bilirubin. The importance is SGPT, that is alanine aminotransferase. It is a more specific marker of liver disease, usually secreted by the hepatocytes, while the AST, that is alanine, that is aspartate, SGOT, besides the hepatocytes, also secreted by the cardiac, muscle, brain, kidney, and blood cells. A ratio is important to differentiating etiology. Like in alcoholic liver disease, the SGOT part is more, and in hepatitis, viral hepatitis, the AST, ALT, the SGPT part will be more. Next slide, please. So we have alkaline phosphatase also. Alkaline phosphatase, it is a very strong indicator of cholestasis, but it is also found in bone and intestine. So the bone pathology should also be ruled out if we are not getting any cause of raised alkaline phosphatase in the patient. GGT, its elevation correlates with the alcoholic liver disease and also with the alcoholic patients. If your patient is taking alcohol, so it will be high in the patient who are taking alcohol currently. LDH has no little diagnostic value. Bilirubin elevated level indicates impaired liver functions as opposed to hepatocellular damage. Bilirubin is very important. The important part is to look into whether it is conjugated or unconjugated bilirubin. Next slide, please. We have a albumin. Albumin, of course, for the most abundant plasma protein, it will be decreases in the cirrhosis. We have prothrombin time. Prolongation of prothrombin time is a sign of advanced liver disease and can also result from vitamin K deficiency. So these are the normal range we normally encountered in normal day-to-day reports. Normal bilirubin, normal range, we usually say less than 1.5. OTPT less than 45 normally we take. Alkaline phosphatase less than 112. 120, I guess. And albumin is 3.5 to 5 is normal. Next slide, please. So, invasive test for evaluation of liver function, ERCP. I would not say that ERCP is basically for liver function. ERCP is for CBT, basically. It is for looking out for CBT. If you are suspecting your patient is having high bilirubin and if you are suspecting any sort of CBT obstruction, then this ERCP. Then ERCP is indicated. We have percutaneous transhepatic cholangiography. It is similar to the principle to the ERCP, except to the contrast agent is injected percutaneously, used when the ERCP fails. Definitely, it is when then the ERCP fail, and it is used to for management of bilirubin if your CBD is obstructed and you are not able to do the ERCP. Next slide, please. Biopsy, yes, biopsy. In fact, it should be mentioned earlier before ERCP and PTC. Biopsy is very it's gold standard. If you are not getting any cause of cirrhosis or liver fibrosis or raised fibroscan score, despite all the tests which came out to be negative, and patient is giving no history of alcohol, then biopsy should be done before all these tests. So we have a percutaneous methods, local anesthesia, it's a OPD procedure. Of course, major complication is bleed because in already liver patients, liver disease bleeding tendency is usually high. So the main complication is bleeding only, and bile leaks, hemorrhage, and it is prone to complications. Next slide, please. Thank you. So this was all about the liver. बेसिकली आज के प्रेजेंटेशन का मेन पर्पस आपको पढ़ाना नहीं था कि आपको पढ़ना है कि किसने सेल से बनाया कितना फंक्शन है. इट्स ऑल अबाउट कि व्हाट डज अवर लिवर डू. इसका कोई ऐसा मेन फंक्शन नहीं है कि जैसे हार्ट का हमको पता है, लंग्स का हमको पता है, बट इसका फंक्शन ऐसे है कि टू कंट्रोल एवरीथिंग. लाइक इट इज विद द कॉपी एंड पेन. लाइक हम जो नोट्स करते हैं ना, जैसे अपनी क्लासेस में ऐसे ही नोट करते हैं कि हमारी बॉडी के अंदर क्या क्या जा रहा है और कितना जा रहा है और इज इट गुड फॉर अ बॉडी और नॉट. तो ऐसा कुछ नहीं कि इसके कुछ सिम्टम्स हो कि जब आपको कोई दिक्कत हो तभी आपको होना चाहिए, तभी आपको टेस्ट के लिए जाना चाहिए. आप जब बेसिक रूटीन टेस्ट कराते हैं तो इट इज एडवाइजेबल टू अंडरगो एन LFT टेस्ट टू रूल आउट एनी सॉर्ट ऑफ लिवर डिजीज. थैंक यू.
Thank you, ma'am, for this wonderful talk. This has enlightened us. So now, with your permission, I would like to ask few questions from you, ma'am.
बिल्कुल.
So, what lifestyle changes can a person make to improve fatty liver condition?
सी बहुत स्पेशल लाइफस्टाइल नहीं जीना है, क्योंकि स्पेशल लाइफस्टाइल कोई भी आप 100% नहीं दे पाते हैं आउटपुट. मोस्ट इंपॉर्टेंट इज वॉकिंग और एक्सरसाइज. 30 मिनट्स ऑफ वॉकिंग और 30 मिनट्स ऑफ जॉगिंग per day. It is recommendable by WHO or anyone, like पर एक हफ्ते में 5 days 30 minutes for 5 days at least in a week. It is advisable. लाइफस्टाइल में अगर देखा जाए तो लोग बहुत कहते हैं हमने चिकनाई बंद कर दी है। सी, चिकनाई बंद करना इज नॉट एन इम्पोर्टेंट। इम्पोर्टेंट इज बाहर का फास्ट फूड अवॉइड करना। एक दिन घर पे किसी, आप फेस्टिव में हो, फेस्टिव सीजन चल रहे हो और आपने एक दिन ले लिया, तो इट इज नॉट एट ऑल इम्पोर्टेंट। उससे लेने से कुछ नहीं होगा, वो उसको लेने से आपको दिक्कत हो रही है, हो सकता है इंडाइजेशन हो गया। द इम्पोर्टेंट पार्ट इज बाहर का जो फास्ट फूड होता है, दैट इज वेरी वेरी हार्मफुल फॉर अस। बाहर के डीप फ्राइड जो फूड्स होते हैं, जो भी बाहर के बन रहा है, हमें नहीं पता वो कितनी बार डीप फ्राइड हो रहा है, कितनी बार उसके अंदर ट्रांस फैटी एसिड्स जा रहे हैं, विच इज वेरी हार्मफुल फॉर अस। सो simple daily walking, simple eating habits, obviously try to take fruits, try to take salad, try to take more water into your lifestyle. That's all, nothing special or nothing बहुत ऐसा नहीं करना कि मतलब एकदम से बदल देना है, ऐसा कुछ नहीं। अपनी नॉर्मल लाइफस्टाइल है, उसको ही थोड़ा चेंज करके, दैट इज मोर देन इनफ फॉर योर लिवर।
with fatty liver disease.
हेलो, हाँ जी।
Ma'am, what advice do you have for someone newly diagnosed with fatty liver disease?
See, it's very important what is the cause of fatty liver disease. If you are suspecting that it is due to alcohol, if your patient is taking alcohol on frequent basis, see, exact amount is not important. Patient will never tell you the exact amount. So we'll discuss he is just taking alcohol on a regular basis or frequent basis. So it is best to stop alcohol, और कुछ नहीं करना है, शराब बंद कर दीजिए, things will improve eventually. यस, द प्रॉब्लम अराइजेस अगर आपका पेशेंट अल्कोहल नहीं ले रहा है या ऐसी कोई भी चीज नहीं ले रहा है, द अननेसेसरी ड्रग्स, द बॉडी बिल्डिंग ड्रग्स, कुछ नहीं ले रहा है, द इम्पोर्टेंट पार्ट इज टू रूल आउट मेटाबॉलिक डिजीज, शुगर, कोलेस्ट्रॉल, थायराइड। ये टेस्ट हमें कराने चाहिए, बिकॉज दीज आर द सिंपल कॉजेज ऑफ नॉन एल्कोहलिक फैटी लिवर डिजीज, जिसको आजकल हम बोलते हैं नेफेल्ट और नैश स्टेटोहेपेटाइटिस। सो बेसिक ब्लड रूटीन इन्वेस्टिगेशन, कोलेस्ट्रॉल, थायराइड और शुगर, ये हमारे बेसिक होने चाहिए। इफ दीज कम आउट टू बी नॉर्मल, अगर इनमें से कुछ भी अब नॉर्मल है तो ट्रीट दैट, सिंपल एज दैट। अगर ये सब नॉर्मल आते हैं तो वेट रिडक्शन इज अ वेरी इंपॉर्टेंट पार्ट। अगर आप थोड़े फैटी हैं, ओबीज हैं अपने बीएमआई के अकॉर्डिंग, तो वेट रिडक्शन इज अ वेरी इंपॉर्टेंट पार्ट। एज मैं, जैसा मैंने पहले कहा, सिंपल वॉकिंग, सिंपल जॉगिंग और सिंपल एक्सरसाइज 30 minutes पर डे इज मोर देन इनफ फॉर फैटी लिवर ट्रीटमेंट। हाउएवर, अगर इनमें से कुछ भी है और आपको रिस्पॉन्स नहीं मिल रहा है 15 to 20 days में, तो it is better to consult your gastroenterologist, nearby gastroenterologist, because there are drugs for that. We have vitamin E for that. We have glitazar for that. We have another drugs like obeticholic and other drugs for that.
Okay, ma'am. And ma'am, there is a question coming out from the audience. Like, I was diagnosed with grade 2 NAFLD last year with CAP score of 270 and EKPA 8.5. And now I am taking saroglitazar 4 mg from the last 1 year. And my LFT is also normal now. So I am going through right treatment or not?
Yes, सी, आप बिल्कुल राइट ट्रीटमेंट पे। 1 year इज आई थिंक मोर देन इनफ टाइम। आपने बहुत ज्यादा टाइम ले लिया है, आप इसको स्टॉप कर सकते हैं। ठीक है, अगर थोड़ा बहुत फिर भी एलएफटी आप, योर दिस कैप स्कोर, दिस फाइब्रोसिस स्कोर इज फाइन, इट इज 8 इज फाइन, लेस देन 11 इज ओके। ठीक है, कुछ जगह कुछ बताते 7 से ऊपर गड़बड़ है, ऐसा कुछ नहीं है, लेस देन 11 इज ओके। आपका फैट कितना है, आपका वेस्ट सरकमफ्रेंस कितना है, हिप वेस्ट रेशियो कितना है, इस पर भी स्कोर बहुत डिपेंड करता है। ठीक है, तो बेसिकली अपना लाइफस्टाइल चेंज तो आपको चेंज करना ही करना है। 1 year इज मोर देन इनफ फॉर योर सारुग्लिटाजार। आप उसको स्टॉप कर सकते हैं। अगर स्टिल थोड़ा सा भी डिरेज्ड होता है, आफ्टर 4 weeks यू विल रिपीट द एलएफटी एंड फाइब्रोस्कैन। इफ स्टिल इट इज डिरेज्ड, तो हम विटामिन ई से कवर करने की कोशिश कर सकते हैं। वी गो विद द विटामिन ई फर्स्ट, देन आई विल एड सारुग्लिटाजार इन माय पेशेंट्स। फर्स्ट आई विल गो विद द विटामिन ई, देन सारुग्लिटाजार। आप एक साथ सारुग्लिटाजार ले चुके हैं, आई थिंक यू कैन स्टॉप एंड वेट एंड वॉच फॉर दैट।
Okay. Thank you, ma'am. So now, on behalf of NASH 24 into 7, I extend our heartfelt gratitude to Dr. Shalini Sharma for her engaging and informative talk. Ma'am, your emphasis on liver health and disease awareness has been truly enlightening and it serves as a reminder of the importance of regular checkups and adherence to medications for individuals affected by the fatty liver. With careful monitoring and precautions, managing the disease is indeed possible. I also want to express my sincere appreciation to our audience for their active participation and unwavering support, which has contributed to the success of this event. So stay connected with Nash 24 into 7 on Facebook for more updates and information. Remember, your health and the health of your family are paramount. Thank you once again, ma'am, and all our participants.
Thank you. Thank you so much.